Very good afternoon, everyone, and thanks for turning up to this session. We call it Cataract Panorama. Have been holding it off and on in various meetings, and especially in All India Ophthalmic Society conferences. And this is going to be a very practical, result-oriented panel discussion where I'll be presenting different situations, and we have a wonderful series of experts who will be taking you through how they will manage that particular condition. I'm sure there'll be several take-home points which you can go back and employ tomorrow. I have in the alphabetical order. These are some of them are just coming in. They're involved in other sessions, maybe coming in a few minutes. But I can see Dr. Professor G188 here, Dr. Shreesh Kumar, Professor Namrata, Shreesh here. Please come to the dais. Others will join as they come in. I'm just going to be presenting different situations and asking the panel to comment on how they will manage. And audience participation is also encouraged, but you have several presentations to go through. So let's limit our interaction for each particular case to a limited extent. I would start off with the basics. What's your primary formula for biometry? Professor Titial, could you?
Thank you for a kind invitation to an interesting session. I think as far as biometry is concerned, yes, it is, you can say primary, but it's the most important investigation as far as cataract surgery is concerned, and that too a refractive cataract surgery nowadays. As far as we are concerned, we do optical biometry for all our patients, and those patients where optical biometry will not give you a proper excellent recording, then you have to do a immersion biometry for these patients. That's a standard for all of us. As far as corneal profiles are concerned, if you can get a good picture from your optical biometry.
No, Dr. Titial, I'm just asking you for the formula. What formula, whether you came from SRKT or...
No, we are all shifted to Barrett Universal for most cases, and if you have a specialized cases, then you look for other options. And SRKT and SRK formula, which was the preferred formula, I think maybe 5-10 years back. So all shifted to Universal now.
Let me give my take on this. As Professor Titial said, Barrett Universal 2 formula seems to be the go-to formula. This is what we also were practicing about 5 years back. But then we realized that very often the Barrett Universal 2 gives you the intraocular lens power that needs to be implanted. But after counseling the patient for a monofocal, multifocal intraocular lens, when you go ahead and put the patient on to a complete analysis, go to the Barrett toric calculator, you see that just for a 0.6 diopters of astigmatism, against the rule astigmatism, the patient actually requires a T3 lens. So on the other hand, if it is with the rule astigmatism of say 0.68, it is a little more, it's oblique astigmatism of a little more than what we saw in the last case, but it's a non-toric intraocular lens that is indicated. So today, each and every patient of ours, once they agree for cataract surgery, even before they meet the counselor, the biometry that we do is a optical biometry. In our case, IOL Master 700, we are various other optical biometers also. But we go ahead and look at the Barrett toric calculator, not the Barrett Universal 2, because that essentially tells us whether the patient needs a toric intraocular lens or a non-toric intraocular lens. Our entire discussion proceeds further based upon that. In case you have just used a Barrett Universal 2 and you counsel the patient because the cylinder is just 0.6 as you saw in this case, and you say that go ahead and get a multifocal intraocular lens done, and then it shows up that the patient actually requires a toric lens. Now, as we all know, in a multifocal intraocular lens, dealing with the cylinder power as completely as possible is extremely important. Then you have to re-counsel the patient for this. That's the reason we go ahead with the toric calculator. Just in case you do not have an optical biometer, you can still go ahead to the ASCRS or the APSCRS websites, and you have the entire range of formula. This is the opening page of the APSCRS website, and you have the entire range of formula available to you. And this is just a note here, almost a similar situation. Against the rule astigmatism of just 0.75 diopters, what's indicated is uh, is a T3 intraocular lens in this particular situation. Mind you, this is not with an optical biometer. The readings have been taken with the immersion A scan and a keratometer. And I've gone to the APACRS website. But same 0.75 diopters of with the rule astigmatism, what you require is a non-toric intraocular lens. So it's a good idea if you have an optical biometer, go ahead and use the Barrett toric calculator straight away. See whether the patient requires a toric or a non-toric, and then counsel the patient accordingly. So oftentimes I'm asked, what is your cutoff for recommending a toric intraocular lens? As we all know, posterior cornea has a significant impact on the corneal astigmatism. So rather than having a number of 0.6, 0.75, 0.8, go ahead and use this formula, and depending upon the axis of the astigmatism, it will exactly tell you whether the patient needs a non-toric or a toric intraocular lens. And then your entire counseling can proceed on those lines. I'm not asking Chitra, Shrish or Shresh on this because I know they're all from our own institution. They basically follow the same principles.
Dr. Ram?
Yes.
I think what he talked about, in terms of with the rule, against the rule, there is the importance of posterior corneal aspect, posterior corneal curvature, which is against the rule astigmatism for most of the time. Throughout the life, doesn't change. So those instrumentation like IOL Master will pick up both anterior and posterior curvature and gives you a TK value. So you have everything in your hand. But there are instrumentation which cannot pick up the posterior corneal curvature. Then you have various nomograms by which you can assess the total keratometric values and assess them. Because as he rightly pointed out, if patient has anterior against the rule, then you're going to undercorrect these patients because you're not looking for a posterior which is against the rule again. And similarly, if you are with the rule anterior and patient has posteriorly against the rule, it compensates the anterior curvature, which nicely shown in the IOL Master. So that understanding has to be there, especially for trifocal lenses, where we say that even you have a 0.75, 0.6, you may require a toric lens, and that is a very important point. Very nicely highlighted.
Thank you. So even if you do not have access to a optical biometer, you can still go ahead to these APACRS or AACRS websites, use the Barrett toric calculator, and go ahead with your presentation. Let's go on to another scenario. Posterior capsular rent and a toric intraocular lens implantation. Let's see how this proceeds. As you can see here, I have done a LRCS procedure for the patient. Everything seems to be under control. The nucleus is coming out. I basically used a grid pattern, and I am going ahead and implanting my intraocular lens, a single piece lens. As you can see, it's not at all an explosive. I'm repeating it just for you. There's nothing wrong that I have done, I think. Sometimes you get an explosive release of the intraocular lens, but then you see the lens almost tilting over, and I try to position it. I've already lost hope. As you can see over here, it just goes in and in. There's obviously a large PC rent over there. And what I'm doing is, this is the lens over here. So what will you do now, Shrish? Would you like to? It's a toric intraocular lens that was planned for the patient, fairly high expectations. As you can see, the surgery went off well. The injection was smooth, but some of this lens is just tilting inside.
It doesn't look like a traumatic implantation of the lens, but maybe the lens has actually damaged the anterior capsular margin rim while injecting it. Instead of going into the bag, I think it must have damaged the margin, and that has
the rexis is intact. I have a large PC rent and the whole lens is tilting inside.
I can still go ahead and place the same lens. So if the anterior capsular rim is intact, we can still go ahead and place this single piece lens in the bag with the optic capture and the haptics in the sulcus. Of course, It is not a it's not described in the textbook, but we can always place this.
Basically, I don't have
A
support here.
single piece lens with the bulky haptics should not be in the sulcus, but in a rare case like this, we can always
But Dr. Ram,
place
it
the
will
lens in the
depend
back
what is
with the
the
optic
axis
capture.
of implantation.
Sorry?
What is the axis of implantation?
Axis of implantation is along the axis of rent.
Then it's a
018.
difficult
It's
scenario.
exactly in this axis.
That should be, you should know that, because if
Yeah.
the tear is in the same axis where haptic is there and that is the axis,
Yeah.
then it will be difficult. Then the only option will be reverse capture, reverse optic capture for this.
So let me see what I did in this case. So basically, as you can see over here, the lens is tilting internally. The first thing was it was just dangling around. First thing is to secure the lens, make sure that the lens doesn't go inside. So though it's not completely recommended, I go in with 2 Sinskey hooks and swing the lens around. And I've actually swung it the wrong way. And I secure the lens in the anterior chamber. And the first thing now is to do an adequate anterior vitrectomy. So I go in with a irrigation. This is actually a moment I'm thinking as to whether what exactly I should be doing, whether I should just take the lens out and go for a 3-piece lens, or I should try to fix this lens inside. If I had a PC rent during surgery, such a large rent, and the astigmatism was also quite low, maybe I would have just gone ahead and placed a 3-piece lens with an optic capture. But this lens was already inside completely, and I decided to just see whether I can fix this lens. And I go in with the vitrector. The irrigation cannula remains in the anterior chamber. The vitrectomy is being done. So it's important. Then I also use a little bit of diluted triamcinolone to ensure that the vitreous evacuation is quite complete and there are no vitreous strands over there. Mind you, this lens is completely reversed now. So I fill in viscoelastic, go in with 2 Sinskey hooks, tilt this around. That's the first step I need to do. And you can see the one of the haptics I brought outside so that the tendency for the lens to slip in is less. Now essentially I slip the lens into the the haptics are in the sulcus now, and basically this you can see me very carefully slipping the haptics just behind the iris margin on top of the rhexis. I go behind the lens, all the viscoelastic that's there, I evacuate it completely, complete the anterior vitrectomy. Once I'm sure it is complete, I go ahead and I have a Varion overlay right through. That will show up towards the end more because of compatibility issues you're not able to see. But you can see the toric markings right very clearly over here. And I've created a good optic capture here. There is, you can see the ovalization of the rhexis margin, and that's the overlay over there, which shows that the toric intraocular lens is reasonably in place. I know it's not a good idea to have the thick haptics in the sulcus, but then this was a situation where I had to do this, and the patient was kept on steroid drops for about 3 months and NSAIDs also. And this is what it was supposed to be fixed at 168 degrees and 3 months post-operatively. Thankfully, it worked out. It's not a take-home message that you can do this routinely, but in this particular case, it did work. Comments on this, Maipal?
So I think, as you said, this has been managed well. The only thing is that you were lucky that it didn't drop or didn't kind of rotate or whatever it is, because the problem in such cases is that you can't even go back and redial, because there's a large opening, there was vitreous that was coming out, etc., etc. So as you said, take home message is not that you should put it and do a capture, because there's such a huge rent as things stand today. Maybe at that particular time when you had you could have gone ahead and put a 3-piece, but technically at times there's a pressure on the surgeon that we have committed for a toric lens and we need to do that. But doing a 3-piece in the sulcus may have been a better idea to avoid any
I request
Mishappenings.
all of you to keep your comments short and
Yeah.
say something which is different. We have quite a few situations
Can
to
I
go
make
through.
a small
Yes,
comment?
yes.
Like in this type of scenario, what I would have done, because has a little softer lens, the haptic may not have enough power to support its a sulcus side, because you are putting the sulcus over the rexus and optic behind. What I would have done, I would have put the lens first over the iris and over the rexus as such, then tuck the haptics behind. So
Cut
your
the-
optic is above the rexus and the haptic goes behind. That's the simplest
Reverse.
it could have been done.
You're talking about reverse optic capture?
Yeah,
Reverse
because the
No.
haptic will not be in the
No, the
sulcus.
reverse optic capture in this case was not possible simply because I don't have any support at the 6 o'clock meridian. The lens had to be at the
That is if you have the rexus intact and rexus size around 4.55 millimeter.
I'll show you
This
the
can
next
be
case,
done
which is a
very
reverse
effectively.
optic capture. Come, go ahead, Namrata.
Sorry, I missed that. But how much was the astigmatism?
Sorry?
How much was the astigmatism? I missed
I think it was about 2.5 diopters.
Okay, so because if it is less, then possibly you can do something like a opposite clear corneal incision and exchange it with a
No, I think
three-piece
opposite
lens.
clear corneal incision hardly takes care of about 0.3, 0.4 diopters.
But leaving the haptics in the sulcus is also not a very great idea.
No, I completely
Yeah,
agree
yeah.
with you. That's not the message we want to send across. But having said that, in situations like this, especially now that torics multifocals uptake is very high and three-piece lenses are not available, and I have experienced occasionally cases like this where prolonged usage of steroids, anti-inflammatory drops, and it stays. Comment.
Just a quick comment on
Basically, the thick square edge haptics in the sulcus is not a good idea, because you can have long term, you can have iris chafing, transillumination defects, and pigmentary glaucoma. So the standard teaching, of course, here you were able to get away with it, but manipulating the lens, it was tilting down, the PCR has gone towards the equator, there's a high chance of the IOL dropping. And when you're kind of flipping it in the AC, you can see that the haptic actually scrapes across the endothelium, and then you can have high endothelial damage also. So ideally for standard teaching, you would just expand the lens, do a thorough vitrectomy, put a three-piece IOL in the sulcus with an optic capture, and then after 3 months, once the patient settles down, you can correct the astigmatism on the cornea with LASIK or incisions, whatever.
No,
that would be
quite
the
agree with you,
standard.
Shri Ganesh, in the sense that that's what supposing I had the PC rent without the lens in the bag, I might have gone ahead and done that. But I'm just showing that these are obviously the reason I'm showing these cases is these are something which I'm done differently. And let's look at this case. And here it was PC rent. You can see the linear PC rent, that was a posterior polar cataract. Here again, I was to implant a toric intraocular lens. Mind you, here again it has to be in 180 degrees. But the good thing here is I have my support at the capsular support is there here and here. The PC rent extends from here to here. And as you know, in these posterior polar cataracts, there is no question of the rent extending. It is a large rent which is extending one pole to another. It's at 90 degrees to the area of orientation of the lens that I need. And so I go ahead and do the anterior vitrectomy. And here again, the astigmatism was about 3 diopters. And what I'm going ahead, it's a Indian toric intraocular lens, and it's a 2.8 millimeter incision. And here what I'm going to do is, because there is adequate support, I'm implanting the lens in the back quite completely. But obviously, because the PC rent is there, this lens is it's going to be difficult to retain it there. We are not sure that the lens will remain in position. So what I'm doing is, once the entire lens is in the back, going behind the optics and bringing the optics alone forward. Here I've done a reverse optic capture where the haptics are in the back and the edge of the optics is in the in front of the capsular rexus margin. Mind you, the point is very well taken that the thick optics or the haptics should not ideally be in the sulcus. In the sulcus, if you have a large PC rent like that, it's a three-piece lens that should go in with an optic capture. So let's not discuss that. But would you do this, Kumar?
Kumar?
I think this is the best way to manage this, because you had the support. There was no other, and you can easily do a reverse optic, and that I was wondering whether that patient was fine with negative dysphotopsia. What did he have in the other eye? Sometimes, we do this in one eye and they don't complain, and the other eye they complain of an arc which is negative dysphotopsia. So I was wondering whether the other eye is same situation, what it is.
Fortunately, there was no complaint of negative dysphotopsia, but I mean, it worked out. This case again.
But why do a reverse optic capture? Because once you have adequate support, and if you have done a limited vitrectomy and there's no vitreous to kind of push the lens, then the lens is quite stable. When you do a reverse optic capture, your effective lens position changes, so you will get a myopic shift, and even the cylinder also, the correction is because of the ELP change, the correction is not so good. So I would just probably leave it in the bag. If it's stable, just leave it there and then it should be okay.
Point well taken, Sri Ganesh. I mean, in the sense, it's just that it's a fairly large rent. So I was not sure that whether the toric lens will stay as it is without rotation. So I did this. Any comment?
Can I come in? No, reverse optic capture, actually, it's a nice way of doing things, but if you look at the anatomy of the iris, it's actually very close to the anterior capsule in the center. The central, the pupillary margin is actually, it touches the anterior capsule, and the periphery, as you go towards the periphery or mid-periphery, there is a gap actually. So instead of reverse optic capture, the regular optic capture will be better in these cases.
Yes, Shreyash.
I think the point, even the previous video was asked where the orientation is. If it is perpendicular, like it is in this, to the direction of the split, then we can implant it and leave it in the bag, and it should do quite well. There is sufficient support for both haptics on the fornices. But if it is like in the previous situation where there's not adequate support, maybe explanting and putting a lens might be the better option, not just for that particular case, but it is a general take-home point. But in this case, maybe just implanting it in the bag would be a great option for this situation.
I think the point is very well taken. The idea of showing these videos these are not normal videos, just run-of-the-mill cases. These can be handled in more than one ways, and our esteemed panel is coming up with other options. Obviously, when the capsular bag seems to be intact and the haptics are resting on capsule which is available, maybe that reverse optic capture was not necessary. But it did work out for me. I'm not saying this is what I would do routinely. By coincidence, that was 168, this is 167. 6 weeks post-op, the lens remained to be absolutely stable. And here again, we got a excellent visual acuity. And these patients have to be maintained on steroid drops and NSAIDs, and as Shri pointed out, transillumination defects, recurrent uveitis are problems that you need to keep in mind. These are the two cases that I showed you. One is where I handle with optic capture, another with reverse optic capture. Somewhat questionable, as you could see, not the entire panel agreed with me, but in this particular situation it worked out. Let's go ahead and look at another situation. I had done way back in 2003, I had done a phacoemulsification with a rezoom multifocal intraocular lens. And in 2015, the patient underwent a YAG capsulotomy. Came for a LASIK opinion in 2022. She was very happy with the kind of visual outcome she had. As you can see here, she has about minus 2.25 diopters of cylinder in both eyes. And basically, I thought I'll just do a laser vision correction for her. But the COBIS, as you can see here, the CBI, the BAD-D, all are suspect. And the TBI, which I do give a certain amount of importance, is absolutely in the red. And it's at the extreme red. And again, even in the left eye, it's almost the same picture. So in this situation, even a PRK is something I would not consider. I actually recommended to the patient, why don't you just wear glasses for the small cylinder that's over there. I said, but then she was insistent on getting something done. So I went ahead and did a piggyback intraocular lens for a small toric power, as you can see over here. The procedure itself, this primary surgery was done almost two decades back in 2003. So I was not sure whether there will be some amount of posterior syndicate to the capsular bag. So injected viscoelastic, freed up the margin of the iris, bloated up the behind the iris, basically the sulcus, and this is an Indian toric intraocular lens. It's a quadrupod design which goes inside, and you can see this lens being injected. Looks quite bulky, but can be comfortably injected through. It requires a 3 millimeter incision to inject this lens inside. And mind you, the primary lens is been done almost 20 years back. And I again have a Verion overlay. That's why there's no marking over there, but it's not showing up on the video. And it's a little challenging to introduce these haptics into the sulcus, but it's doable. And you can see the haptics of the primary lens behind this. And subsequent to the surgery, the patient ended up with a very optimal outcome. The near vision was already taken care of by the rezoom lens, which very well functioned for this patient. Ended up with a situation like this. Comments from you, Chitra?
So what was the corneal thickness?
Huh?
Didn't hear. What was the corneal thickness in this case?
Corneal thickness was, frankly, I can't tell you, but as you can see here, this is the primary reason. I mean, I think the thickness was in a normal range, but as you can see over here, the Corway showed that the bad D is, the TBI is absolutely in the red, both in the right eye and the left eye, and the CBI is beyond 0.5, and the bad D is 1.8, 1.9. She's a 30-year-old, had one baby, was contemplating another pregnancy. But at the same time, so I did not want to take any chances of doing a laser vision correction. Obviously, if the corneal thickness was good, no questions asked, I would have gone ahead and done a laser vision correction.
Topography was totally normal.
No, let's look at this.
More than the question of whether PRK could be done in this patient or not, the option of using an add-on lens, I think, is a great option, not just for just correcting this astigmatism, but even in patients who, let's say, have had monofocal in years past and desire multifocality now, and the other eye has now developed a cataract, we are very often able to tell patients that you can have this add-on multifocal in the sulcus, and which can give you excellent multifocality. And of course, toric multifocals are also available, which can give us very good correction.
Now, for a myopia, you would give the same power, and for hyperopia, you would multiply by 1.5. For just sheer astigmatism alone,
it's just the same principle. If
and
it's minus
myopia?
2.25, you just implant a minus 2.25. So basically, I think we have to understand that, as Shesh was mentioning, these piggyback lenses gives us great options. I think I have 1 or 2 more videos coming up also.
Rama,
So, apart from-
one thought on this was, I have used a add-on Sulcoflex. That design of the haptic is very different from the design of this haptic.
That's not
Now this goes against all the principles of putting a single piece square edge, all over square edge IOL in the sulcus. So I understand, and this is made by AIOC2023. So I told AIOC2023 if they can manufacture like a Sulcoflex. If you remember, the Sulcoflex design was like this. So I want to know, because they have to have different sizes, right? Now this looks like a overall particular fixed size. So did you optic capture in the CCC? Can you optic capture this design?
No. I don't want to do a optic capture. First of all, the primary surgery was done 20 years back. So obviously, the capsule have fused over the optics completely. There's no question. Even if it was possible, the reason you have interlenticular opacification or red rock syndrome is because both the lenses are in the capsular bag. So the Sulcoflex lens always goes in the sulcus. And this is made up of hydrophilic acrylic material, and it has a rounded edge. So this lens is, I think, you can get it from Sulcoflex lens, but they are not readily available. You have to order for it, and the expense on those lenses is much higher than this.
The Sulcoflex is ready now. Yeah, like you said, it's not ready and it is more expensive. So I would just put in a phakic IOL, and that also works very well. So that is, if you are not able to get a Sulcoflex, then even a toric ICL works very well.
So where would you place that faking IOL? Just behind the
In
iris, just like you do normally?
Yeah, just like normally you do.
No, I do agree. I have put up a couple of lenses, but when you discuss with Star or they themselves say it's off-label, the likelihood of it being
Even
stable
for
is not there.
keratoconus, it is off-label, but we
No,
are all using it.
But
so-
Dr.
Also the
Ramamurthy, how many
rotational
of such
stability of
cases,
the lens.
Yeah.
how many of such cases would you have done?
Rotational stability of the phakic
No,
IOL
I mean,
is
if
pretty
you
good.
are asking about overall,
Numbers and
but
follow up.
if you're talking about overall piggyback lenses, I must have done at least 100 of them.
And
But just
follow-up?
a small toric power like this must be one or two cases.
One or
like
two
this.
cases,
Yeah.
okay.
But these toric, there have been quite a few piggyback torics, even toric multifocals I have implanted, and they remain fairly stable over a period of time.
Just a point, in case phakic IOL is being used, we would probably have to oversize it a little bit because now the anterior chamber depth will be much larger and the potential for rotation or mobility will be more compared to a standard eye where the space is much lesser in a phakic eye.
But basically, when you're doing the calculation, you're taking the ACD. So the
Larger
ACD
ACD.
actually will be more. So automatically you get an oversized lens.
And,
Just one last thing that I wanted to ask Shreyas. You said that you could use a toric multifocal as a piggyback.
It is available in toric multifocal also, madam. They
But
have
have you
multifocals.
used toric multifocal
I've
as
used
a-
only multifocals. Maybe
I've
he would have
used-
used
I've
toric
used.
multifocals.
as a piggyback?
As a piggyback. You know, when a patient, I think one of the videos will come.
And what happens to the optics? I mean, multifocal over a monofocal.
No.
And nothing,
The primary lens is a hydrophobic intraocular lens. The basic thing is the material of the two lenses should be different. So the second lens which is going in, that's why most piggyback lenses are made up of hydrophilic
Hydrophilic
material, and they don't have a square edge. Also, they have a rounded edge because you don't want any iris chaffing. So let's look at this IOL explantation. And as you can see, it's a 3-piece lens I've implanted, and you see the trailing haptic is missing. So that's broken over there. So this is just a fairly straightforward video, but for some of the youngsters, I just wanted to show this would be the way I expand the lens. And the various ways of doing this, of course. I inject a lot of dispersive viscoelastic to protect the cornea, and then go in with a lens holding forceps through the side port, get a grip on the lens, and this could have been a better grip than this. And there is special serrated forceps that's available to us. It's available from our Indian manufacturers itself. And you just 1/4 of the cut is enough. You need not go all the way out. And if the haptic was there, like a single piece lens, I would have brought out the haptic. I'll be showing it in the next video. Then I go ahead and we use a McPherson's and then gently roll the lens out. And you have to be, in case you just directly pull on it, it can just extend, only half the lens might come. But if you're doing this rolling movement like the way I'm doing, then the entire lens comes out in its toto. And these are not very elegant surgeries, but these are things that you need to do sometimes. And that's the entire lens, which is 1/4 cut, which has come in. And now, of course, the lens which was primarily needed to go in will go in. We'll have the discussion after this.
Just one
moment. I mean, this is extreme case of improper IOL labeling. You can see that the patient needed a plus 28.5 with a plus 3 diopter of astigmatism. And that's exactly what I had ordered. And gone ahead and implanted the lens. Very surprisingly, the patient had a plus 7.5 diopter residual error. We racked our brains. We repeated the IOL master. Looked at the second eye the fellow had already undergone surgery a week earlier with excellent results. And they showed a slightly higher power, but there's no way we are going to get a plus 7 diopter refractive surprise. So ordered exactly the same power, and then we had to go ahead and exchange this lens. So mind you, I mean, this doesn't happen very often, and not that it happens only with Indian manufacturers. Once in a while, this kind of a wrong labeling of the intraocular lens power is also a cause for refractive surprises. As you can see here, I had spent almost a month before the second surgery was done, and it was a hydrophobic acrylic lens. So a certain amount of adhesion is there. The pupils do not dilate too well. So basically, I'm injecting viscoelastic and separating the rexus margin from the lens, going behind the optics of the lens, pulling the lens forward and bringing it completely forward. This is entirely an avoidable complication where the whole problem has occurred because of wrong labeling. We ordered exactly the same power the second time around with the same manufacturer. We have used quite a few of their lenses with reasonably good results. So that's the lens which is being brought out. And now I'll bring the single piece haptics outside, because that gives me more stabilization of the entire lens. We get the lens holding forceps, bisect it, bring the lens out and inject the lens of the same power inside. Comments please. Someone wanted to already say something.
I think I would have put nylon hooks because
Sorry?
I would have put iris hooks.
You could
Because
have,
I wouldn't have,
yes.
I would be more comfortable to dilate the dilated pupil and
I
then
understand.
kind of
I agree with you.
look at the
first
back.
case actually is interesting because what you see is the trailing haptic, the 3-piece lens, the trailing haptic has come out. So if it was still there, the trailing haptic, you can actually push it into the hole there and insert the same lens. And I've done that before. Or if it is not available, then you can
I know
take
you are
another.
there, I know Sri Ganesh, you are there. So I thought about it. You see the small bit of haptic
It's broken.
haptic.
Okay.
So it's not.
So
otherwise
sometimes it just comes out,
Yeah,
because
it could have been
they
inserted.
just drill a hole and put it in. So then you can actually take another lens, pull out the haptic from that lens and push it through. And then when you place it, because of the pressure, it does not come out and it remains centered. So you don't have to expand it.
Wrong labeling. Anybody wants to comment on this? Any experience on this? The tolerance level as far as labeling is concerned
What was
is
the-
about what's allowed by the FDA is 0.3 diopters. That's the reason we do not have 21.5, 21.75, etc. Because when you say you are a 21.5 lens, it could be anything from 21.2 to 21.8. That's a kind of leeway that's given by the agency itself, though most manufacturers try to avoid this kind of a problem.
Wrong labeling is actually, if you look at the process in the factory, what they do is they manufacture it batch wise. So if it's like a 21.5 adapter, then that particular day they manufacture only 21.5 adapters and then label it, so that the lenses don't get mixed up. So it is quite rare that this kind of, because that is a standard process which is followed by most IOL manufacturers. So having such a difference of about 7 diopters, there must be something terribly wrong.
Yeah.
And you'll have to look at the other batches also.
No. I mean,
so once you explanted that lens,
we sent it back.
You sent it back, and did they actually measure the lens? And
they are
see
still
the
at it.
diopter?
This happened just about. They have not really got back to us. We are asking them why this happened, but this has. I mean, they wanted the lens back, and we're giving it to them after cutting it down. Yes, Kumar.
See, one comment was about wrong labeling. This happened to me with the Rainer IOL. What happens is it comes with an extra plastic foil. So we never realized this, but it was actually the plastic foil is stuck with a gum that peeled off 1 out of the 18 diopter. So it became 8 diopters. Okay? But the beauty is what we then realized is that this labeling is done on both sides. So then we started checking both sides. So it's very important that when there is an extra plastic foil on a box, you have to check both sides of the box to make sure what is, because sometimes when they take off the plastic, that one comes out and it will be a wrong IOL. So we actually had that episode, and yeah, that's, no one checks inside.
No,
because
nobody double
we
checks.
check
No,
outside,
that's the
then
thing.
we just give the IOL.
Did you look at the stickers? Was it the same?
Yeah. We looked at the sticker. Actually, I showed you the discharge summary where the sticker was there, and that shows 28.5. And let's look at another scenario. I mean, there are a lot of LASIK patients who are coming to us for surgery now. And this patient, as you can see from the chart, it was done almost 20 years back in our own clinic for a significant myopic astigmatism. Had a very good result. As usual, we said phaco. This was way back in 2015. And so at that time, putting in a multifocal intraocular lens subsequently in a post LASIK eye was a strict no-no. So we said phaco with aspheric single piece. We used the Barrett 2K and there was no cylindrical power that was needed. And this is the formula you resort to whenever there is a post LASIK patient that needs surgery. And we ended up with a very good result. And the patient was due for the other eye surgery. was very keen on something to be done for her near vision also. She was just around 50, 51 and said that I was telling her that we can never be sure about the results. You might require glasses outside. Even after the surgery, near vision is not possible. Symphony was just coming in. That was in 2015. So we had a significant discussion with her and went ahead and implanted a Symphony intraocular lens in the second eye. I'm not showing you the surgical procedure, nothing very different. As you can see over here, the right eye with a Symphony, in spite of all its deficiencies as far as near vision is concerned, ends up with a N6 near vision, and the patient was extremely happy. She didn't want anything done for the second eye, and her kind of visual requirements, she was not an office goer, and was taken care of. So basically the concept of putting a multifocal intraocular lens in a case which has undergone LASIK, nowadays I don't hesitate even to put in a trifocal intraocular lens, provided these things are qualified, these things are taken care of. That is post LASIK treatment. If the patient was not happy with the type of visual quality or quantity, then that's a strict no-no. But if the patient has enjoyed a decade or two of excellent uncorrected visual acuity and the basic procedure had gone well, you can go ahead and do this. I need a stable refractive outcome which has lasted the patient for quite some time. The topography should be all green, very minimal higher order aberrations. Then we go ahead and try these lenses. Any comments, Rayesh?
I would agree. I mean, if there is a regular topography with, and possibly the patients we'll see in the years to come will all be patients who do not really undergone the older lasers, but the flying spot lasers where the aberration profile is going to be much better. So definitely these are patients who can be candidates for multifocal IOLs in the future. One additional point would be to have a good look at not just the topography, but also have a look at eye trace or any other.
No, that's why minimal higher order aberration. We did see the eye trace. Yes.
See, you can look at the holiday EKR graphs, and you look at the curve there, the distribution of the case. So if it's a nice Gaussian distribution, you know that your cornea is fairly regular. So I always look at the holiday EKR graphs before I decide, and of course the higher order aberrations. Because if you have even a little bit of decentration, then you have coma. And if you have coma, then these lenses don't do very well. So a little bit of spherical aberration there, it's more forgiving. But if you have coma, then so you need to specifically look at whether they have coma and whether the EKR distribution is good. Those two things are good, then you can go.
Any comments?
The other thing is, because some loss of contrast is going to be there for a post-refractive surgery patient, the ideal thing would be to do a non-refractive IOL like a Vivity.
No.
Multifocal IOL. It's just, I'm just saying it for a sake of
if
discussion.
you would want, I mean, what would your choice be?
But the amount of loss of light in a Vivity is much less than in a multifocal.
Yeah. No. Yeah. So if you have to choose between a EDOF and a trifocal, what would you choose?
Frankly, EDOF might be more forgiving. So I might introduce something more like a synergy rather than a conventional trifocal intraocular lens in this situation. Yes, Shrish?
I agree with Dr. Chitra. These are the patients who have high expectations, and we should not promise them that they will be able to see all range of vision without glasses.
I basically wanted to bring about this concept,
enjoyed good quality vision after LASIK. They expect the same after cataract surgery. And I suggest these are the patients are good candidates for non-refractive, non-diffractive EDOF lenses. That is like
the trouble is, I've never been too satisfied with the kind of near vision they give. Invariably they require a +1, 1.5 near vision. This lady was not a driver at night. Her visual requirements.
Yes, what happens is these myopes, they are used to keeping material a little closer.
No, she was very well corrected.
No, the retina also is stretched. So they don't have that kind of visual acuity as hyperope or normal patients. So they would want a more higher plus for reading. So the EDOF may not give them a full kind of reading. So that's another point.
Synergy could be the best option, if not an EDOF.
Let's look at this. This is a very conventional surgery. Um, the viscoelastic of my choice is HPMC, which goes in. There's a reasonably hard cataract, and after staining, and because all this entire chopping is taking place in the capsular bag, I'm not really bothered about the health. It's a normal cornea, health of the endothelium. But as a routine for all my cases, once the nucleus is chopped, you do say that you do a posterior plane phacoemulsification. Once the nucleus comes out, I think it's in the anterior chamber. So this is what I do, in the sense that give a coating of dispersive viscoelastic. I commonly use Viscoat, which has no financial interest, and make sure that it nicely coats the endothelium. But at the same time, if it's full of Viscoat, then this is thermogenic also. That's the only case if you have Viscoat completely filling the anterior chamber, and then you activate the phaco. That's the only situation nowadays where you end up with a phaco burn. So essentially what I do after coating the endothelium with the Viscoat is to introduce some HPMC, which is a sort of a modified soft shell technique that I use. That's HPMC that's actually going in. So most of the phaco action takes place in a lake of HPMC, while the dispersive viscoelastic, which doesn't flow out easily, continues to coat the endothelium. So comments on this? I mean, what do you feel? What's your choice of viscoelastic? Do you think there's some sense in what I'm doing?
I have had this. If you overfill the chamber with Viscoat, it does not allow the heat to dissipate. So you will end up with a wound burn in a hard cataract. So what I do is I fill almost 2/3 of the anterior chamber with Viscoat, and then the one third near the wound, I fill it with HPMC, so that the heat dispersion at the wound is better with HPMC, and this kind of helps.
No,
so I think it is logical to kind of mix HPMC and...
But the classical soft shell technique is that you put Viscoat first and then put Heal-On.
Yeah.
So yeah, but you're using, but Dr. Ramamurthy said he's using HPMC, and you are saying you don't completely fill, but you only fill 2/3. But the technique which was described by Steve Arshanov was a complete fill of Viscoat plus a fill of Heal-On.
That is for IOL implantation to maintain the chamber, but this is when you're doing...
that is not for IOL implantation, that is for phaco only.
See, that is maintenance of chamber while doing capsulorhexis. Like Ultimate Soft Shell, he uses Heal-On 5 and he uses BSS, so that the BSS has less resistance to doing capsulorhexis. So it's easier to do capsulorhexis. But while doing phaco, you need a dispersive viscoelastic like Viscoat to protect the endothelium when you're in such a hard cataract. But at the same time, you don't want a wound burn, because the Viscoat does not allow dispersion of the heat. So that's why you can put in HPMC near the wound, basically, so that...
So for once you're agreeing with me.
100%.
Oh, fantastic.
No,
you made my day.
But I just want to make a point here. If you've only filled 2/3 of the chamber with Viscoat, 1/3 is the one, which is not still
basically,
coating
Namrata,
the
if you
endothelium.
saw, I'm just gently coating the endothelium. It's just a film of...
So you're not kind of completely filling.
Sorry?
You're not completely
filling it. And then I'm filling HPMC and then going ahead with the rest of the procedure. Maipal, you have been quiet for very long. Any comments?
Another flip side of putting Viscoat is that when you do phaco emulsification, actually, especially for hard cataract, you would have fragments, which will get stuck to the back of the cornea because they get trapped in Viscoat. That free movement of those fragments is not there. So sometimes you may even have to, address them.
Address it, yeah.
So if you use a high flow rate, then that should not be a problem.
Yeah, that should come out.
I think the point here is more than using a soft shell is fine, but even if we are using only a Viscoat, like let's say if we are doing a patient with a Fuchs dystrophy, you want good uniform coating of the endothelium with the Viscoat. Idea is we don't go into phaco 3 directly, do a little bit of aspiration, create some space. There is already some BSS which is pushed in close to the capsular bag, and then if we do the phaco, the wound burn should not be there.
I think that's a very important point. Basically, if in a well of Viscoat, if you just go inside and activate phaco, that's the only situation now with all these hyperpulse and modern phaco machines, you get a wound burn. So essentially, you have to be in foot position 2, aspirate a little bit of viscoat, create a lake of irrigation fluid BSS, and then go ahead with phaco. So instead, what I'm doing here is to have a lake of BSS to do this, and just continuing on with the surgery. About a year and a half back, I saw in a live surgery, and since then, I've almost completely switched over to this hydro implantation. And as you can see over here, my irrigation cannula goes all the way in almost up to the other pupillary margin. It gives a very stable chamber. I can do even a wound assisted implantation, and this is the intraocular lens that's going in. So I find that it's really time saving, because you don't have to spend time evacuating the HPMC that you have injected. And even if it's a toric intraocular lens, you are able to get are able to do it quite well. I think there's a toric lens that's going in. Comments, how many for hydro implantation?
I normally implant all my lenses under hydro, but I don't have an irrigating cannula. I just fill the antechamber with BSS, and I just hydrate the side port, and it's a closed chamber. I just inject the lens under BSS, and it just goes into the bag. So I'm comfortable doing that. We did a study comparing.
But what about toric, Sri Ganesh?
For torics only. For torics, we did a study, injection under BSS, injection under viscoelastic, and we found that the amount of rotation is much more within the viscoelastic group rather than the BSS. Because with the BSS, what I do is I inject under BSS, there's no visco to be removed, or maybe very little, whatever is there in the cartridge, which I wash out. And then when I hydrate, I leave the eye a little soft. So what happens is the bag collapses over the lens, and so the rotation, incidence of rotation is less. If you have viscoelastic and especially HPMC, you can't remove it completely. So there's some amount of HPMC left behind, and this causes an IOP spike post-op. And when there's an IOP spike, the bag expands. And when the bag expands, especially in myopic eyes with the bigger bag, there's a tendency for the lens to rotate. So hydroimplantation, and it saves time because you don't have to put visco, you don't have to remove visco.
I think I had my own concerns about it, and but now having started using it and pretty late in the day, I'm very comfortable with it. I think each and every one of you should try this with the irrigation cannula inside. It at least cuts down your surgical time by a couple of minutes, and especially with toric intraocular lenses, the positioning of the lens seems to be very easy. Let's look at, but it's not always good. This is a case, I think the reason I landed in this problem is because of a hydroimplantation. You can see a diffractive rings of this patient. You can see this is not absolutely well centered, and when I dilated and saw this patient, this was very recent. You can see a certain amount of decentration, and she had got the other eye done. This was again got the second eye done. Was extremely happy with the outcome. 6/6 vision and 6 in both the eyes. And she is a school teacher, wanted to get back to school. The beginning of May, I hardly did the repeat of the surgery a couple of weeks back. She was very reluctant to get anything done. She said, "Doctor, I'm seeing very well. I have my near vision, distance vision, everything is good. Why do you want to mess around with my eyes again?" So, would you do anything at all for this eye, or just leave it alone as such?
One haptic is in the bag and one in the sulcus.
This is what I saw after dilatation. I have the same doubt as you did.
Yeah, the
So
upper one
basically-
looks to be in the sulcus. So if it's in the sulcus, then I would still dilate back into the capsular bag, because over a period of time with capsular contraction, the decentration will get worse.
Absolutely. I also agree with you. I mean, in the sense that, I didn't, in spite of the patient's hesitation to get anything done, I said, this is not the way I want to leave the lens behind. And I'll do.
Was this a flax rexis or it's a manual rexis?
Manual rexis. So basically, let's see what happens during surgery. I had to literally convince the patient to come back for surgery. And it was not just one haptic, Sri Ganesh. Both the haptics were in the sulcus. And it was not intentional.
So
and
you
maybe
again
it was
disagree.
because the pupil came down and it was a hydroimplantation. Not that this happens very frequently. So basically this I did about 6 weeks after the primary surgery. and that's a little bit of viscoelastic that's going in, and I try to bloat up the bag. I thought it's. I also suspected this one haptics must be in the sulcus, and I just have to rotate it inside. But then when I started positioning the lens, I realized both the haptics are inside. I wanted to open up the capsular bag. It was so using an iris repositor and opening it up. And other side also we did the same thing. And subsequently, Maipal, you have been very quiet. Any comments? Let's know whether you are awake.
No, I think short comment is that obviously if they're out, you have to put them in. That's about it.
Sorry?
If it's a sulcus placement and there's a decentration, you have to put it back, and I think that's about it.
So the thing is, sometimes the outcome is good. Patient is very satisfied. She had 6, 6 and 6. She was very reluctant. She said, my school is opening. Why do you want me to come back for another surgery? I have no problem at all.
No,
and as you can see here, both the haptics were in
this might have been there right from the beginning, actually.
Sorry?
Maybe this was missed earlier on.
Yeah, this was missed. She came back for a 1 week post-op checkup. That's when we noticed that the lens was in the decentered like that. And this was what we saw. At 1 week, normally we don't even dilate the patient.
Yeah, but you
can see the decentered rings of the diffractive ring.
So intraop, if the pupil comes down a little, how do you know whether the lens is in the bag or one in the bag, one haptic in the bag, one haptic in the sulcus, or both out in the sulcus? So you have to do what is known as a bounce test. Okay, the bounce test, bounce test is when you pull the lens and leave it. If it is in the bag, then it automatically centers. If one haptic is in the sulcus or both haptics is in the sulcus and you pull it to one side and leave it, it does not automatically center. So because probably you had this difficulty, the pupil came down and you are not able to see the margins of the rexus. So when you can't see the margin of the rexus, you just do the bounce test and see. And then if you feel that the bounce test is abnormal, then you can retract the iris, just check whether it is in the bag, and if it's not in the bag, then you dilate it.
And if you, on the table, if ever you see diffractive rings like this, then definitely attend to it right there and then. I mean, it's absolutely abnormal. The lens is not well centered and it needs to be taken care of.
And if you see striations in the posterior capsule, there's also a short sign that you're in the back.
Actually, I like to see a little bit of striations on the posterior capsule.
Yes.
Because if you don't want an overfill of the capsular bag, and seeing a linear line in the capsular bag,
if you have removed all the viscoelastic,
yes,
then and if the bag is not too big, then you will see these striations.
Yes.
And that is okay. Only thing is post-op, if you have striations, post-op the patient may have what is known as a Maddox rod effect, where when he sees lights, he will see a line and he will come and complain. If it doesn't go away you assure him that it will go away by 3 months. If it doesn't go away, then you have to yag it.
Yeah.
So I think we do big time refractive surgery, and definitely recently we have added on Prelex to our armamentarium. Last 3-4 years the numbers are going up. It's definitely a strict no-no for myopic patients, but this is my typical patient for Prelex. A 54-year-old. I mean, this is the profile of this particular patient. Socially active, no night driving. Son actually underwent SMILE by us just a couple of weeks earlier. And then when she came for the post-op checkup, she said, my son is doing very well. What about me? Can't you do something? I hate wearing glasses. And this is the kind of refractive error she had, plus 2.25 and a small cylinder with 2.25 diopters of watt power as far as reading is concerned. And the IOL master showed that both eyes, no toric lens was needed. We went ahead and did a Prelex with the trifocal lens. Kumar, you might come across such patients quite often. Do you do this Prelex?
I think for Kumar, sorry, that's for you.
Yeah. After we use the same lens also. We prefer the trifocal because that's when it's really necessary. We are doing this now on the system quite often, but only thing is then we would prefer with sometimes one may need to combine it with an LRI also.
Yeah, Basically, if you have done using a laser, you'll use laser arcuates. Otherwise, LRI for the small astigmatism.
So I would prefer laser LRI. Right now I'm doing it. I was never doing it on the previous system, but with the new system I'm getting excellent results. I've gone till 3.5.
Why?
I've never done it on Catalyst. I don't know why. But I'm doing it on this. I'm doing it very regularly
So I
for
think
a
the
small
new-
cylinder, which is in an odd axis like 25, 23, a 1, 1.25.
No, previously we used to think that clear lens doing surgery on that is absolutely unethical. It's wrong. Definitely, in a case of myopic patients who are less than 45, 40, etc., I would agree with that. But this kind of a patient profile nowadays, we have the eye trace also, where we look at the dysfunctional lens index. Sometimes in 55, even though the patient is reading well, the dysfunctional lens index will show you it's 0.3 or 0.4. So it's a rigid lens, not accommodating. Then doing surgery like this and implanting a trifocal intraocular lens, obviously you will discuss with them all the what demerits of putting in a multifocal intraocular lens, dysphotopsia, glare, halos, etc. So if the profile of the patient fits in and if they are okay to accept this, then we are doing this with reasonably good results.
Just for the sake of discussion, if this patient had good anterior chamber depth, would you prefer presbyopic phakic IOL over prelex, or still go ahead with prelex?
Basically, I have 3 different categories, in the sense that under 40 is just classic, 40 to 50, 52. It's basically we go put a presbyopic phakic intraocular lens. Nowadays, trifocal phakic intraocular lenses are available. Or if it is beyond 50, 55, then I go in for a prelex with trifocal.
I would do press beyond, and this is what I've been doing, because if you have a clear lens and if you have a DLI over 5, and then the patient has excellent contrast, good vision, and once you put in a multifocal lens, the contrast is going to dip. So in a patient with a cataract, the contrast is very poor. So whatever you give them, they are happy. But in a patient with a clear lens, you do a prelex and put in a trifocal or a multifocal, then the contrast dips. And then they have dysphotopsia at night. If they are active, driving at night, then they can be miserable. So why not do because I have got a presbyon done 8 years ago. And I have excellent night vision, excellent contrast, and maintaining 6.3 and J1, no on glasses. So if the patient, my only indication for a prelex is if the patient has a narrow angle, occludable angle, then when you do a prelex, the angle is going to open up and the chance of angle closure attack is not going to be there. The second indication is, of course, if an astronaut comes to you and is going to space, then of course they are definitely going to develop a cataract, so you have to do a prophylactic cataract surgery. These are the only 2 indications.
No, but Shirigan, just for the sake of playing the devil's advocate, you got a press beyond done. All of us had a press beyond. It's still not picked up. What is the reason as to why are the results indifferent?
Somehow, press beyond, yes, it has worked for you. You do it in good numbers. We completely believe that you're getting good results.
Almost 30% of my refractive practice is press beyond. Many of the practices now, almost 50% of them are press beyond. If you look at Dan Reinstein's practice and many others in Europe, it is understanding the procedure, evaluation of the patient, then very accurate refractions, and it will give you good results. And I have had patients who are very happy, and my presbyon practice is growing much faster than my other smile or LASIK practice. So I think it is. I think the patient satisfaction can be extremely good if it is done well. And the other advantage is if the patient develops cataract, you don't have to put in a multifocal or anything. You just put him in a regular monofocal and then keep the non-dominant eye about 1.75. They are already neuroadapted and they have excellent distance and near vision.
But Sameer Shah got a press band done and he had to get a retouch up done, and now again he has problems. So I have people.
You can have anywhere from 10 to 30% enhancement.
Yes.
Because you have to be exact. You have to hit the mark in the dominant eye. If you are not within 0.25 diopters, then there is no summation. So the patient will be unhappy. So if you are very accurate with your fluence testing, with your refraction and your outcomes, then patient satisfaction is good.
The quick point I wanted to make with regarding the presbyopic phakic IOL is that all of these procedures, Presbyon, Presbymax, Custom Q, the concept is of inducing a certain amount of spherical aberration. There is a certain difference in quality of vision between a pristine eye and an eye which has undergone this procedure. And definitely with the multifocal IOL also there is a certain dysphotopsia which is induced. All of these, the problem is we are not sure which patient will adapt, which patient will not adapt. With the presbyopic phakic IOL, the only advantage is it is completely and truly reversible. So therefore, if a patient is uncomfortable with their quality of vision, you can reverse it, which is possibly not available with these options.
With Presbyon, you just have to wear glasses to balance. You don't even have to reverse
residual
it.
error, but for the quality of vision, there is
Quality of vision is excellent.
I just like to pass on. I mean, obviously, there are more than one option. So we have a presbyopic phakic IOL, we have Prelex, we have Presbyon. So obviously, there are more and more active people in their 50s, 60s who want to lead a very active, complete life, freedom from glasses. I think in the years to come, we'll hear more and more of these things. LRCS and soft and medium cataract, this is what I do now. I mean, if you can see, I don't use a grid pattern. I don't use any circle, just a sextant. And after removing the excess, I basically just hydrate through the central incisions. And that sort of completely opens up. Just look at the CDE. I remove the loose cortex and the epinucleus. Then go ahead and it's practically each of those sextant, the segment, pizza pie is completely separate. And just because I did a hydrated through the central incision, which have been created through the laser, and there is hardly any phaco power that's needed. This ASM actuation is another discussion. And slightly harder cataract, even in these cases, I find that it works quite well. This is obviously not a grade 3 or something, but it's grade 2. And doing a little bit of hydrodissection, rotation of the nucleus, and subsequently I remove in these cases which are slightly harder, I remove the cortex and the epinucleus, then go in again. Usually sometimes it's with just hydro, sometimes it's even viscodissection into the incision. You can practically see that incision just splitting up and go through the side incisions also, and this completely cleaves. And please have a look at the CDE. Not that my objective is to boast that I use 0 CDE. I think phaco power should be used wherever it's needed. But even a grade 2 cataract like this, which has undergone a laser procedure, can be completely cleaved by doing a hydrodissection through the incisions and splitting up those nucleus fragments into separate pizza pies, which can be easily removed. Yes, Kumar.
See, what people who don't have a femto don't realize that there is big advantage in femto is that there is already a pneumatic plane behind the nucleus. So when we do a hydro procedure, even if you don't do a hydro procedure, you've done flax and you start phaco, your fluid will find that plane and automatically do a hydrodissection. So that's one big advantage. And then we don't need to really rotate the nucleus because you already broken it into different pieces and then remove. And also there is no doubt that the amount of phaco energy used is 50% less than the ones without flax. So that's also proven now.
So here again, both of you will agree because he demonstrated this viscodissection about a decade ago.
2012, we described the technique of visco chop and published it.
You did it in the live surgery
in Jaipur also. And the advantage is you don't need, if you do a visco chop, you put viscoelastic, you have a hydraulic separation of the different fragments. You don't need a second instrument like a chopper. So you can do a one-hand technique. So if you don't have a chopper, then the chance of damaging the anterior capsule or creating a PCR with a chopper is not there.
Yeah, but Shri Ganesh,
you have 3 pieces and then you have high vacuum and high flow. All these pieces come to the center and it's very fast.
I think I'm doing exactly that. I used a vacuum about 600 and there was no chopping that was done. The chopper was just being used to feed in the nucleus segments, and the phaco probe was kept right in the center.
But actually, the amount of energy that you use is very little. So it's just a thing of showing that you can do a visco dissection.
So let's see a capsular bag getting caught. Everything seems to be going according to plan. And you see that. I have not actually paused the video. It's just that I'm waiting for this. I hope some youngsters are watching this. And as far as you don't move the phaco probe and hit the reverse button, then it gets released. But I have created a capsular dialysis. So basically what I do is you can see the dialysis here superiorly. So there is cortex still, but the moment I inject viscoelastic inside, it bloats it up. And that's the endocapsular ring being introduced through the side port. I think it's an easier way, and completely avoid the area where the dialysis is there and go to the area where the capsule, the zonules are still intact, and introduce the endocapsular ring in a very gradual controlled manner. This kind of a peaking of the capsular bag tells me that the ring is going into the right place. And once when it's almost inside, then we use 2 Sinskey hooks, one to hold the eyelet of the endocapsular ring, other to guide it through so that it doesn't slip into the angle, and then the ring is slipped in. Subsequently, of course, you remove the cortex tangentially and then implant the intraocular lens. Any comments from any one of you? Yes.
In such
How did
cases,
it cause the dialysis and not a PCR is what I'm wondering. I mean, you caught the PC.
no, the capsule is very elastic, and there was some amount of epinucleus there, which probably protected the capsule. So the pull caused the zonular. So it depends upon what gives way first. Whatever is weaker gives way. So here it's probably the zonules. The other thing is, while inserting the CTR, probably the support should be against the area of zonular dialysis, so that that it does not pull the bag to one side. And you can use a capsular hook in such cases, because when you use a capsular hook, you have a nice support, and then you can remove the cortex also and then put in the CTR.
Any comments, Kumar? I think you have a whole video on how to introduce a endocapsular ring. You want to say something?
So one, as you said, always start inserting the endocapsular ring away or opposite from the area of subluxation. If you suspect. Now here, you are not suspecting, it was just the whole bag which came up, but it was weak zonules, so you just give an extra support. And insertion is right from the side port, and then just keep dialing in. And the last part, I always like to do a bimanual technique. So I'll use a T in one hand and a Sinskey hook to get the eyelet of the endocapsular ring engaged. So the T will prevent it from sliding into the sulcus, and you can actually pull the T towards you and put it into the bag. So that's one big advantage. Only one additional point here would be that the cortical stripping will not be straight, because you already have an endocapsular ring. It has to be tangential. So that's one additional care that they will have to take.
I think the technique of mine is also bimanual, as you can see here. Basically, I'm using one Sinskey hook to ensure that the endocapsular ring doesn't slip into the sulcus, I mean to the angle, and the second one slips it inside.
One question, if you had a central PCR along with the dialysis, what you would have done?
I would have called you up. No, I think that's a difficult. Definitely, if you have a PCR, it's not a good idea to implant an endocapsular ring.
You can do a PCCCC.
Yeah.
And then put a ring.
Yeah, but
You get a punch out. See, when
let's
when
look
this
at
happens, you get a punch out.
Panchorex.
Let's look at this problem. I use a Lisa toric lens in this case. As you know, it's a plate haptic lens, and nothing special about the surgery. And as the lens is going in, I thought everything was under control, but I'm injecting the lens inside. It goes in through I usually use a 2.4 millimeter incision. So this goes in almost, look at that. I mean, the lens is reversed.
Yeah, the landmark.
Ideally, in this kind of a plate haptic lens, the leading left edge should have the hole and not the right. So the very fact that it's reversed, I did notice it, but somehow I went ahead and implanted it.
Got confused with the ICL because ICL it's always
Yeah, so it's a toric multifocal lens, and I'm going ahead and implanting it. Any other lens, a 3-piece lens, a single-piece lens, I would have gone ahead and reversed it because it's hydrophobic acrylic. The square edge is posteriorly. There is angulation of these lenses, but this particular lens is planar, and I decided to that is the orientation of the toric angle. I did not reverse this lens, and because of this, I checked with the company also, and this is the refractive outcome we had, where both the cylinder as well as the near vision was completely taken care of. So we have to understand where this reversing. I'm not suggesting that we do this routinely. This happened as a mishap, but there was no need to flip this lens back again because it's a planar lens, and the toricity is supposed to be distributed both in the anterior and the posterior surface, and it works out well whether you implant it the right way or in the reverse way. All other lenses, if it flips, obviously you have to flip it back.
Because it's a bitoric without angulation, you're able to get away with it.
Correct.
But the other thing is with the Lisa, the rings are usually on the anterior surface. When you implant it the reverse way, then the rings are in the posterior surface. So basically, the effective lens position, there's a little difference. You may get like a 0.25 diopter shift or so, but it may not be very significant to affect the visual outcomes. But if there was an angulation, or if it was not a bitoric lens, then it's ideal to kind of flip it and put it in the right way.
What you say is true. That's what the literature from the company also says. Distance vision will be totally unaffected. But as far as near vision is concerned, there could be a addition of plus 0.25 or something that's necessary.
But it's very easy to flip over these lenses. Very easy to do that because the landmark, until of course one is confused that the landmarks were fine. The moment you are going in, you can actually.
And this is a toric IOL in a post-hyperopic classic done long years back. You can see a sea of red in the center because it's hyperopia that was corrected, and the central curvature is about 49. And this was the right eye and the left eye of the same patient. And this is the formula that needs to be used whenever you are using a post-toric, post-classic situation. The Barrett toric 2K formula. As you can see here, it shows a need for a plus 36 and a plus 2.54 is the cylinder. And these lenses can be custom made. This is the lens that was made by the company. And the surgery itself is fairly simple. You will also see the box being shown with this such a extreme power. So even in this this is obviously not a multifocal intraocular lens, but you can use this kind of the right formula. Because of the high power, I needed actually a larger cartridge for introducing this lens, and that's the reason I'm enlarging the incision a little. And that's actually the power of the lens at plus 32.5 with a plus 4 diopter cylinder incorporated in it. It's a custom made lens, and the lens is being implanted. That's the end of surgery. And what you can see here is there's a small cylindrical, but the patient got much better vision than what he had right through his life, whether before LASIK or post LASIK. Almost the complete refractive error had been taken care of. Of course, the quality of vision is something that we can discuss about. But obviously, because when you're doing pure hyperopia, you're creating a central bulge forward, and that causes a significant amount of aberrations. But this patient ended up quite happy.
Would you err on the side of myopia or hyperopia when you're looking at the biometry in such cases?
I think I would err slightly on the side of hyperopia.
Yeah, you have to err on the side of hyperopia because basically many of these formulas, they look at the K readings and derive the anterochamber length, ACD, and then the effective lens position from the curvature of the cornea. Here the curvature of the cornea is artificially steepened, so it thinks that the ACD is bigger, and so you can get a little bit of a myopic shift post-op. So it's better to err on slightly on the hyperopic side if you want to hit an.
But actually in this case we just put spot on whatever power was given, and it worked out. And just an IOL scaffold Morgagnian cataract like this, obviously these cataracts come with extremely fragile capsule also, which tend to trample in, and it's easy to get caught even if you're using a high-end phaco machine. So in this case, because it was not really a hypermature cataract, doing the rexes was not a challenge. But as you can see, it was just a hard nut, and this is something which will flop around. So what I do in this situation is just to bring the nucleus in and nucleus out, and then place an intraocular lens that needed to go into the bag, and using a lot of dispersive viscoelastic. It's not really a hard cataract, and it cracks easily. I go ahead and it's anterior chamber phacoemulsification. So filling in the dispersive viscoelastic is important. But having that diffractive, any intraocular lens inside the bag is obviously makes the surgery so much safer. Any comments, Shreyesh? You want to say something? Yeah.
I mean, the IOL scaffold is an option. In case the nucleus is a little larger, there also, I mean, the bag will still be floppy, it will come up, but it may not be a good idea to prolapse the entire nucleus into the anterior chamber. In those cases, maybe even putting in a CTR would reduce the floppiness, and then we can continue with the phacoemulsification.
True. The point well taken. Basically, CTR will also stretch the capsule so that it doesn't, the tendency for it to come up is less.
What I like to do is use Helon 5, because that acts like a kind of support, like an artificial epinucleus which is there. Because here there's no epinucleus. The cortex is completely liquefied and the bag is very loose. So it has a tendency to just come up into your phaco-port, especially when you're, and you cannot really do sculpt techniques. You have to do a chop. And sometimes, you salute the lens, like Dr. Keki says, and do a direct chop. But then suddenly the PC comes up. So if you use Helon 5, that kind of pushes the PC back, and then you can remove the nucleus.
Won't it have a tendency also to easily come out as a bolus? Very easily.
No, as soon as you... No, Helon 5. Helon GB comes out as a bolus, but if you're using, it is viscoadaptive, so it does not easily come out, especially if you don't have a high flow rate.
I think we discussed this earlier also. Nowadays, we are coming across patients who have had a monofocal in one eye, and then they come for had a relative or a friend who got a multifocal lens done. They get the multifocal in the second eye. What about the first eye, which has a monofocal lens? So very often, even with one eye operated, these patients are quite happy, and they don't really want anything further to be done, and their near vision needs are taken care of. But this is an option that is there, and as I was mentioning earlier, you get even trifocal diffractive, toric lenses, and it's very easy to slip this in. And it is a hydrophilic material, and it has a plus 1.75 for intermediate and a plus 3.5 for near. Absolutely no financial interest, but they are reasonably cost effective also, and you could consider them wherever a patient who has had a extremely well done cataract surgery with a lens nicely seated in the capsular bag, having good distance visual acuity, wants something to be done for the near vision. Of course, if there is some residual error also, you can still go ahead and do this. Any of you have done this? Any experience with these lenses? No, Shreyesh, I think you guys have used it.
Used a few multifocal. I have not used any multifocal torics, but I've used a few multifocals, and they're all quite happy. It's definitely a viable option for patients who are earlier one eye monofocal done, or even now worried about again the this option is again quite easily reversible also, and it can be removed if necessary.
It's a hydrophilic
Actually, what I've
lens.
found, Rama, that if they have done it in one eye, the multifocal, and the other eye is the monofocal, they're quite happy.
Yeah.
And they may not need. But here, my question here is, what is the add in this trifocal piggyback?
It's 3.5 and 1.75. 3.5 for near
So
and
it's sufficient.
1.75 for intermediate. Basically, I absolutely agree with you. Majority of patients, even with one multifocal, are quite happy. There are some who want more. This is a very simple technique that I do. I think most of the other surgeons here also, I see them doing in their live surgery. You see all these small fragments over here. After taking out the nucleus and doing the cortex, just going in with a 24 or 25 gauge cannula and then just hydro polishing. I don't know what benefit as far as the vision or even quality of vision it has, but it gives you a very nice, clean posterior capsule. And more than polishing the rim or the anterior capsule or anything, doing this hydro polishing is something that I do routinely, apart from some other steps that I showed. Any of you do this? Any comments? It's a very simple step, and any one of you can do it. And I just feel that you can incorporate this before implanting the lens.
I use a 27 gauge cannula so that the jet is finer and you get more force with the 27 gauge cannula. And I also go close to the fornices of the bag and then inject it because this causes stripping of those lens epithelial cells in the equator which you can't reach. And it is much safer than using a mechanical, say a Nightingale polisher or vacuum polishing, because then it's a no-touch kind of a technique where you're trying to clean the capsular bag and the PC. So I use it all the time, and it's a very good technique to use. And sometimes when you're doing coaxial irrigation aspiration, the subincisional cortex, you may not completely be able to remove it. Then you go from the side port and just flush and then do this hydro polish, and then it loosens the cortex and it comes out.
I think we have time for just a video more, one or two more videos. This is a phaco in a posterior polar cataract. And what if it's not a soft cataract, it's a grade 2, grade 3 cataract. So obviously you cannot just suck the nucleus out. So I do a hydro delamination, 5 millimeter rexis, then subsequently removing all the loose cortex and the epinucleus. Basically, I'm just going to create a small trench, and through this trench, I am doing a phaco chop. The inferior heminucleus, I am breaking it into 3 segments, and I have done no hydro dissection in this case. Once it is done, these nucleus fragments tend to come out quite easily, and once the part of the nucleus has come out, there's no pressure on the posterior capsule. Then I'd go ahead and do a hydro dissection, rotate the other part of the heminucleus inferiorly, then go ahead and remove it completely. And lastly is removal of the epinucleus with the posterior polar element, and that's I think a multifocal or whatever intraocular lens that has gone inside. So I think this is helps me when we have a formed nucleus. Let's look at this video also. And obviously we have all seen so many videos of posterior polar cataracts being handled, and there are multiple ways of doing this. And here what I'm going to be doing is to again adjust a hydro delineation, and you can see the nice golden ring. And I use a vacuum of almost 600 in this case, IOP being kept at 30, and I create a nice groove. And I feel that more than doing a direct chop, in these cases doing a stop and chop helps, because that gives me, without any hydro dissection itself, splits up the nucleus into 2 halves, and then I mobilize the nucleus fragments and take them out completely along with the epinucleus and then implant the lens. Any comments on this? I think these are fairly standard techniques.
Yeah, I have the rescan. So what I do is I do a OCT and then look at the PC. And only 27% of these posteropolar cataracts actually have a dehiscence. So if there's no dehiscence and I see the antravitreous is clear, sometimes when you have a dehiscence, you have some kind of particulate matter in the antravitreous. So if the antravitreous is clear, if the PC is very clear, then I go ahead and do a hydrodissection. Otherwise, if you don't do a hydrodissection, then removing the cortex takes much longer time and it's more difficult. But if there is a dehiscence, sometimes pre-op you can see it on slit lamp, or even intra-op with the OCT you can make out the dehiscence. In such cases, I do a hydrodelineation and I'm very careful.
Yes, Kumar.
So one thing is 100% that I'll do an OCT, and another thing, all these patients I will do a flax. There are 2 advantages. You will get a CCC of 5 millimeter, which protects you, and you will keep a larger margin in case we have a doubt, and you got your segments, so it will make your life much more easier. So even if the patient doesn't pay, we still go ahead and do flax. Another advantage, flax itself has OCT. So there itself also you can double check what your anterior segment OCT has done. and that itself will give you a guideline.
I think very relevant points that are being made, and I think today for a posterior polar cataract preoperative evaluation, OCT must be a standard of care. And if you see some cortical matter in the anterior hyaloid, that tells you that the chance of getting a PC rent is very high. But sometimes it's just a fibrosis thing, and it's continuous line. The chances are extremely low. What is said about this is that it's a very high negative correlation, in the sense that if you do not have cortex in the anterior hyaloid, chances of getting a PC rent is extremely low. But that does not mean the other way around it doesn't work. So you can be fairly, as Sri Ganesh said, if you don't find anything and it's a continuous line, it's a fibrous line, then maybe these cataracts can even be handled like a routine cataract surgery. I think I have a few more videos, but that brings us to the end of our time. It's 4:30, and thank you so much, panel, for all your excellent inputs, and thank you all for joining us.